Dear colleague, welcome to the third part in this course, where we will continue with the early history of psychiatric neurosurgery. Some of you might have seen this famous photo of Spiegel and Weisses, who introduced stereotactic functional neurosurgery in humans in 1947. But almost no one has read the heading under the photo, New Brain Operation for Mental Illness. Stereotactic functional neurosurgery was introduced with the specific intent of reducing the side effects of lobotomy. The first procedure was anterior thalamotomy for psychiatric disorders, and here they reported results from the 18 first procedures. The target was chosen based on the theories first presented by Walter Freeman, and they were congratulated by him. Stereotactic procedures with mechanical lesions, alcohol and procaine oil injections, cryosurgical lesions, focused X-rays, installment of radioactive seeds, and eventually radiofrequency lesions were soon performed in various brain targets. Other lesion techniques were also tried. Petter Aron Lindström started using ultrasound lesions in the frontal lobes in the mid-50s. Lexell used a proton beam in 59, first applied in a psychiatric patient, and later he devised a gamma knife. And the scientific interest was great, judging from the second and third International Congress on Psychosurgery in Copenhagen and Cambridge, respectively. The most common stereotactic procedures were the cingulotomy, capsulotomy, and to some extent the tracheotomy. And it is perhaps not so difficult to understand how these came into existence if one considers that these are all located in the plane where a typical lobotomy would be performed. For historical reasons, cingulotomy was the preferred procedure in the USA and capsulotomy in Europe. The effects of cingulotomy and capsulotomy are similar, but it seems as if the capsulotomy is more efficient but also carries a higher risk for side effects. The tracheotomy was a more uncommonly used procedure. If we start with the cingulotomy, then the open cingulotomy was suggested by John Fulton already in 47 and introduced in 48 by Lebeau in Paris, later to be performed stereotactically by Foltz and Wyatt. But it is most well known thanks to the work of Ballantyne. Different targets have been used by different surgeons along the cingulum. If you would like to have more detailed information regarding this procedure, then please consult the lecture on cingulotomy. Talleyrand, who started his career as a psychiatrist, considered the brain to be too important to be left to the neurosurgeons, and introduced the open capsulotomy at the International Neurologic Congress in Paris in 1949. At the same meeting, Spiegel and Weisses presented their stereotactic technique, Fiamberti, the transorbital lobotomy, and Almeida Lima, the prefrontal leucotomy. Lars Lexell, working with the psychiatrist Torsten Hörner, then introduced the stereotactic capsulotomy in 1952. Concerning the results, these were reported in 61 in 116 patients, and 50% of the patients were said to have a good outcome. Other groups have presented quite varying outcomes, some with very good outcome and few side effects, while others have not been so fortunate. It is likely that this is to some extent due to differences in the size and location of the lesions, since capsulotomies were mostly done during the pre-MRI era, when the target structure could not be identified with any certainty. Different locations along the whole anterior limb of the internal capsule was targeted. We used to be quite anterior, while, for example, Borsaco was very posterior, close to the bed nucleus of stria terminalis. There was further large variations in the size of the lesions, and larger lesions would often include neighboring structures. The capsulotomy of Lexell were further developed by the psychiatrist and later neurosurgeon Gunvor Kullberg, who also became the first to perform studies on changes in regional blood flow after capsulotomies and cingulotomies. If you would like to have more detailed information regarding the capsulotomy, then please consult this lecture. Jeffrey Knight introduced the stereotactic subchordal tracheotomy in 64, and Laurie Lightingen the subgenual cingulotomy, which is targeting the same area as the tracheotomy, but through another approach, and this is actually the most common target for DBS for depression today, the subcingulate gyrus area 25. and sometimes a combination of the dorsal cingulotomy and tractotomy was used, named as limbic leucotomy by the psychiatrist Desmond Kelly. Another less commonly used target was the amygdala. This had been targeted already by Wortel Freeman using the transorbital approach and blood injections based on the technique of Maurice Ducoste. The stereotactic amygdalotomy was first introduced by Spiegel and Weiss for epilepsy, but is more well known from Narabayashi, who used this target for aggressions. And you will find more detailed information in this lecture. A more common target for aggressions was the hypothalamic area. Walter Rudolf Hess shared the Nobel Prize with Egas Moniz in 1949 for his animal experiments in the hypothalamus, and the first hypothalamotomy was performed by Spiegel and Weiss in the same year for aggressions. A very simplified view of the hypothalamus might be sufficient for an everyday understanding of the different procedures. There are variations, but there are basically 4 target areas. And the only area that is used today is in the posterior area, which is divided into a medial and lateral part. The medial area was the most common target for hypothalamotomies, introduced by Sano for aggressions, and is today used mainly in DBS for cluster headache and aggressions. The lateral area is where the medial forebrain bundle and often limbic STN is targeted or implanted. It is mainly stimulated in depression and obsessive-compulsive disorder. More anterolateral, we find an area which has been used without much success for obesity. And finally, deeper down, we have the ventromedial or anterior area, which is mainly of historical interest and has been targeted for sexual deviations, hedonia, obesity, and other strange indications. Stereotactic lesional procedures were first used for psychiatric disorders, but it never attained any widespread popularity. But it came to revolutionize the treatment of movement disorders, and the same is true regarding deep brain stimulation, which was first developed for psychiatric disorders before being applied to movement disorders. Regarding early DBS, what I believe to be the first case of deep brain stimulation was performed non-stereotactically in the caudate nucleus by Lawrence Poole in 1948 in a woman with anorexia and depression, and favorable results were reported until the electrode broke after some weeks. Later the same year, he applied the same technique to the gyre singly. Another pioneer in this field was the neurophysiologist José Delgado. He is well known for his experiments with the brain control in animals, as in this video here from the bullfighting arena, but he implanted also humans with psychiatric disorders as early as 1952. The first use implanted externalized electrodes for testing outside of the operation theater was the Norwegian psychiatrist and neurophysiologist Carl Wilhelm Sem-Jacobsen, who presented this technique in 1953. These electrodes were used for stimulation, sometimes during months, in order to identify the optimal site for incremental stage lesions. Tulane psychiatrist Robert Heath started a chronic stimulation program in the early 50s. Eventually he focused on finding the pleasure center of the brain and concentrated on the circuitry between the septal area and the medial forebrain bundle and the nucleus accumbens. He implanted about 60 patients with up to 29 electrodes in each, and rather strange and questionable experiments were performed. In the video here, we see him talking with a patient who is repeatedly pushing a button and self-stimulating, and she describes the pleasurable effects of the stimulation. The first used chronic depth electrostimulation as a therapy was, however, Natalia Petrovna Beshtereva, a neurophysiologist in Leningrad. Unfortunately, most of her publications were in Russian, but from the late 60s and onwards, her group treated approximately 200 patients with OCD with externalized DBS. Several electrodes were implanted, and the patients were treated with intermittent courses of stimulation for up to 1.5 years. The last step was, however, microlesions performed through the electrodes that provided the best response. The technological development progressed, and the first use of chronic DBS with a quadrupolar electrode and a neuropacemaker was Gert Dickmann from Saarbrücken in 1979 in a patient with phobia. However, DBS for psychiatric disorders was at this time a marginal phenomenon of very little impact. And it ended with the so-called psychosurgery debate. When we discuss this, then it's important to realize that the introduction of stereotactic functional neurosurgery did not result in an abandonment of the lobotomy. It was too expensive and required access to an operation theater, stereotactic equipment, and a dedicated neurosurgeon. In reality, what made the lobotomy subsequently obsolete was the introduction of chlorpromazine in the early 50s. The critique against the lobotomy was to a large extent voiced within the medical community. The more fierce debate mainly outside of the medical community belonged to the 60s and especially the early 70s, when stereotactic lesioning had all but replaced lobotomies. The psychosurgical debate during the latter period was mainly driven by the liberal press and by groups on the far left like the Senkakuren in Japan. And as I mentioned, the major impact of stereotactic functional neurosurgery, both regarding lesioning and DBS, was within the field of movement disorders. This was the first effective treatment for Parkinson's disease, and in 1967 more than 25,000 patients had been operated. But then came the decline of stereotactic functional neurosurgery following the introduction of L-DOPA. Very few procedures were being performed during the following 2 decades, and this lasted until the reintroduction of Lars Letzell's posteroventral pellidotomy in Umeå by Lauri Laitinen in 1992, and more importantly, to the introduction of modern DBS by Benabid and the Grenoble group in 1987. DBS has revolutionized the treatment of movement disorders and is today a well-established therapy with more than 230,000 implanted patients, and the success of DBS for movement disorders created an interest also for its potential use in psychiatric disorders. But that is the topic for the next lecture, and with that we end this lecture. Thank you for your attention.